All right, guys, so thanks for coming to another one of these talks about wound healing. So this is the third episode in this series, and a lot of the information from this book is, of course, based off of Peterson's oral maxillofacial surgery principles, as well as the first aid to the USMLE Step 1 and OpenStack's Anatomy and Physiology from Rice University. So let's keep moving right along. So where we are now is bone healing. So let's talk a little bit about bone healing. So bone is one of the very few tissues that regenerates rather than repairs. And when we think about regeneration, remember that regeneration is the ability to have structural and functional healing that looks almost identical to the natural tissue or the native tissue. So when bone is left to heal spontaneously or without intervention, we get indirect healing. And we have a thrombus that minimizes the excessive bleeding from the Haversian canals. So indirect healing is essentially just a sequential tissue formation and differentiation. And so what is a Haversian system? Well, a Haversian system is also known as an osteon, and it's the microscopic unit of compact bone. So inside of each of these Haversian systems is a Haversian canal, and running down the center, you'll see an artery or vein or a lymphatic vessel. Or actually, I should say you'll see all three of those things. Okay? So, looking at bone healing now, indirect healing essentially is made up of these 5 steps. So, at first, we have necrotic material. It's tracting the polymorphonuclear cells or leukocytes at first and then macrophages later. And when we think about polymorphonuclear leukocytes, we're thinking of neutrophils, basophils, and eosinophils. So then we have thrombus. The thrombus at the fracture site starts to serve as a fibrin scaffold. A soft callus starts to form via inflammatory cells and mesenchymal cells. And when we're talking about the mesenchymal cells here, these are pluripotential mesenchymal cells. And their deposits are going to start to fill up that interfragmentary gap. Now, the soft callus starts to serve as the splint, and that soft callus is made up of fibrous tissue, cartilage, and immature bone. And lastly, we start to have tissue maturation and differentiation, which leads to fracture consolidation. So those are the 5 basic steps of indirect healing, and that's healing without much intervention. So now when we think about direct healing, that's the kind of healing that we get when we surgically intervene, or intervene at least in some fashion. So generally, direct healing is due to surgical manipulation and fixation to reapproximate and realign the bone. So the bones are going to be surgically manipulated for realignment, and the bones are going to be rigidly stabilized with internal fixation devices, and the result is anatomic reduction. So the second step here is that mesenchymal cells and blood vessels begin to deposit osteoid, and osteoid is being deposited at the fracture ends. So the third step is that contact zones are filled concentrically with lamellar bone. And what are contact zones? They're essentially just closely approximated areas within the fracture. So when you think about a fracture, you might get, when you try to reapproximate everything, you might get pieces, that do fit together just like the part of the puzzle, but some pieces might have, kind of broken off. And so we have these gaps, and those interfragmentary gaps are the large gaps that are filled in step 4 with a succession of fibrous tissue, fibrocartilage, and woven bone. But the big principle here is that via surgical manipulation and rigid fixation, the fact that we'll have no microinstabilities is going to result in direct healing without the callus formation. So, carrying on with this idea, the original shape and architecture are going to be restored via the remodeling process. And what carries it out is the basic multicellular unit. And so the basic multicellular unit is essentially just a combination of osteoblasts, osteoclasts, osteocytes, and the blood vessels that bring all those cells and their precursors. And growth, differentiation, and activity of these units, these BMUs, are determined by local factors. So one thing that helps us understand the fate of these different cells is understanding their origin. And so you'll note that the osteoclasts, they come from the monocyte or macrophage lineage, while the osteoblasts and osteocytes are derived from pluripotent mesenchymal stem cells. So factors affecting the BMU activity are things like growth factors, cytokines, and different mechanical signals, and that is a pretty big deal. Because when we think about different mechanical signals, so actually one of my favorite books I've ever read is called The Bodybuilders by Adam Pure. I'm not sponsored to tell you about this book. This is actually just one of the books that really grew my love for science, and I think it's a really easy book to read. And they talk about every chapter talks about a different, like a biomedical or technological advancement. And there's a whole section on stem cells and regeneration. And what they found is when they take stem cells and they give them different stimuli, maybe it's electrical pulses or some sort of strain or something of that nature, they actually start to differentiate into different cells that would have undergone those pressures or those kind of those mechanical signals. So mechanical signals are actually crucial. So looking at this here, we'll see that this right here is the BMU. So what we have is we have osteoclasts right here on the leading end, right? And the precursor cells are coming from this blood vessel, like we talked about. And then we have osteoblasts lining this trailing end here. So the osteoclasts are almost paving a path for these osteoblasts. So I said osteoclasts, sorry about that. And osteoblasts here are going to be starting to deposit osteoid. And when that osteoid starts to get larger than 6 micrometers, the osteoid begins to mineralize. And so you start to get this new bone, okay? So another thing to think about is when these cells die off. So the osteoclasts inside of each of these units generally die off within 2 weeks, but the osteoblasts take much longer, with the majority of them usually dying within a few months. Roughly 60% of those die off within a few months, and the rest become osteocytes as they remain inside the mineralized matrix. So osteocytes are mature osteoblasts. Okay, so BMUs continue to replace reparative tissue with mature bone, and if you think about bone almost like wood, what we notice is that the grain begins to parallel the compression and tension forces that are applied to the bone. And the strains and external forces are crucial to bone regeneration and remodeling on a structural and cellular level. So low levels of strain, which is around 2,000 microstrains, are needed for remodeling, cell differentiation, bone matrix formation, whereas excessive strains, which are greater than 2,000 microstrains, and they end up causing problems with osteoblast activity and differentiation. And that just speaks a lot to the importance of mechanical signals on bone formation and maturation. So looking now at the different types of ossification and how each fracture healing type leads to different types of this ossification, we'll find that the unstable or unsupported fracture, so we think about indirect healing, right? You'll find excessive motion near and within the fractured area, which results in endochondral ossification. But stable and supported fractures, you actually have intramembranous ossification. So what that means, if you think about it like practically, what that means is that on the unstable unsupported side, you end up having cartilaginous callus that becomes new bone. But you skip the entire callus phase inside of the stable supported fracture with the intramembranous ossification. So, thinking about bone healing, okay, there are a bunch of things that really go into it. Fracture reduction is a big one, the fracture configuration is another big one, and the microstrain is a big one. So the magnitude of the microstrains and the direction of the the orientation of the microstrains, they play a big role. There's the two factors when we think about microstrains. And when we think about fracture reduction, we think about the accuracy and its stability. So if the fixation can't be stabilized, then the intrafragmentary microinstability causes osteoclasts to continue to resorb the margins of the fracture, and the result is a widening fracture gap. It can eventually heal via secondary healing and endochondral ossification rather than direct healing. So if you don't do a good job accurately and stably reducing the fracture, then you're going to end up, your goal is direct healing, you end up with indirect healing. And essentially, it'll likely manifest clinically as non-unions or fibrous healing. So that's a lot about bone healing, and bone healing is important because bone healing is definitely a part of extraction healings, right? So when we think about extraction healing, now we're moving a little bit away from just bones in general to extraction sites, okay? So in between 24 and 48 hours, we have the following things progressing. We have blood filling the extraction sites. We have the intrinsic and the extrinsic clotting pathways activating. Then we have clot organization, vessel dilation, and then the leukocytes migrate and the fibrin layer begins to form. So the clotting process is facilitated by the intrinsic and extrinsic pathways. And the second part of those 4 steps results in the fibrin meshwork, which seals off torn blood vessels and reduces the size of the wound. I can't tell you where I read it, but I remember reading that they say that an extraction of a molar is one of the biggest hematologic insults that people can actually undergo, which I thought was pretty bizarre. They say, if you're able to, go through that with no issues with bleeding, then you'll be able to undergo most things without any issues with bleeding when you're trying to evaluate a patient's, hemostasis, when you think about doing other operations on them. So Now, in the 7-day time span, 7 to 14 days, I should say, first, the clot serves as a scaffold for cells, okay? And then osteoclasts begin the crestal resorption. And inflammatory cells, they begin to migrate onto that scaffold, and that is the clot. So the epithelium grows onto the scaffold from the periphery of the wound. Now, in the third part of this process, from 7 to 14 days, we have angiogenesis beginning in the PDL, and then the clot continues to organize. And organization occurs through fibroplasia, all while blood vessels are making their way to the center of the clot. And lastly, we start to see trabeculae of osteoid growing into the clot. Now, 14 days onward, first we start to see the extraction socket filled with granulation tissue, and then we start to see completely re-epithelialized wound surface with minimal or no scar formation. And then in the third step of this 14 plus days, we start to see immature bone begin to form at the wound perimeter. And it begins to be radiographically noticeable between 6 to 8 weeks, but final healing product is only visible radiographically within 4 to 6 months. Okay? So, looking at delayed healing, so a clot can fail or disintegrate. That's definitely one reason why we can have delayed healing. We can end up getting localized alveolar osteitis and healing delays and gradual socket filling. And that gradual socket filling, with this defective healing, the affected socket typically remains either open or only partially covered with hyperplastic epithelium. And then healthy granulation tissue is also very crucial to bone apposition into the socket. So that's just a little bit about delayed healing. Okay, so now we talked about bone healing, we talked about extraction healing. We're going to talk a little bit now, we're going to switch modes, and we're going to talk a little bit about skin grafts. Okay, so the organization here is based primarily off of Peterson's Principles of Oral Maxillofacial Surgery. So if you want to follow along with these lectures, I recommend you actually look at that book. So looking at skin grafts, when we think about skin grafts, we're thinking about two different types of grafts. We're thinking about full thickness grafts, and we're thinking about split thickness grafts. Okay, and so the difference here is that a full thickness graft has the epidermis and the epidermis within the graft. And the pros of this are, of course, that it's less susceptible to trauma. It's not as frail, right? And there is minimal shrinkage. But now when we think about a split thickness graft, we still get the entire epidermis, but we get varying amounts of the dermis. We have 3 different types, depending on how much of the dermis you take with it. We have thin, intermediate, and thick. And the pros of these are that they're actually quicker to revascularize. And in addition to that, they have a greater clinical survival rate. So there are definitely indications for either one. So thinking about skin graft and host graft interactions, what ends up happening, what we see is that host capillaries are providing nutritional support, and host leukocytes begin to infiltrate the graft. And the biggest thing to note is that graft survival is directly correlated to neovascularization. So host capillaries are dilated, and the plasma that exudes from them provides the nutrition for these grafts. Specifically, the host leukocytes make their way into the lower layers. And just thinking about the proximity and the size of these things relative to the amount of space you might find in the wall of a dilated capillary. So graft survival is directly related to the success of neovascularization of the graft, and the ingrowth of host blood vessels must end up forming anastomoses with the vasculature in the graft. So that's crucial. We need neovascularization in, but we also need anastomosis with the vessels that are already within the graft. And the success of neovascularization is signaled by a pink tinge in the graft by the 3rd to 5th days. So when we think about skin grafts, 2 days out, what's happening, underneath is that endothelial capillary buds, they start to make their way to the epidermal junction. And the perfusion of the graft by the host capillaries can be seen, like we said, around days 3 to 5 by that pink tinge. And then on 4 days, the host fibroblasts invade the layer of fibrin and leukocytes found inside the graft. The fibrin clot slowly resorbs and continues to organize as fibroblasts continue to infiltrate the graft. Now at 9 days, we start to see fibroblasts and blood vessels that we start to see that they've anchored into the graft. So there's significantly more stability. So when it comes to reinnervation now, for reinnervation, the nerve fibers typically follow the donor's neurolemmal cell sheaths, and they maintain the same innervation pattern. Sensory recovery begins usually within 2 months, but sensory recovery is not usually as good as the original skin. The 2 most common complications here are, of course, wound dehiscence and infection. So, a little bit about infection. Infection is going to be impaired healing from bacterial load, of course, right? So it occurs when bacterial concentration, many studies show that when the concentration of any bacteria exceeds 1 times 10 to the 5th organisms per gram of tissue, that you're going to end up having an infection. Now, there, of course, are some bacteria, it doesn't even take that much to cause an infection, and that is based off of their pathogenicity and the host's immune response. So what we end up seeing is this kind of endless cycle. It starts with wound infection, then we get host immune system stimulation, the production of inflammatory mediators, and some of these inflammatory mediators are things like prostaglandins and thromboxane. But now in the 4th step, we start to see neutrophils migrating and enzymes and reactive oxygen species, and ROSs, okay, which are free radicals. Because of this, we start to see thrombosis and vasoconstrictive metabolites, and from that, we start to see wound hypoxia. And of course, we'll see this later when we talk about hyperbaric oxygen therapy, which is the exact opposite of this. When we get hypoxia, we actually see that we start getting cells working with anaerobic metabolism, which of course promotes further proliferation of bacteria that are anaerobic, right? So this is an endless cycle because that wound hypoxia is actually now beneficial for that wound infection. So it's kind of a slippery slope here. So more about infection is that the damage from the bacterial, we can actually get damage from the bacterial breakdown, right? Because we know that in some bacteria, we have things like lipopolysaccharide, which is LPS, endotoxins, neutrophil proteases, and new cells are susceptible to these toxins. So even the disinfection period is damaging to the immature tissue, which causes impaired healing. So maybe mature tissue can handle things like LPS and endotoxins, but what we'll find is that immature tissue doesn't have the structural integrity to handle all those things. And many bacterial species do indeed have those breakdown products. So typical signs of infection, of course, are rubor, dolor, calor, and tumor, which I think we've either gone through or we'll go through soon. So when we think about the ideal environment for bacterial growth, we think about these 6 things. We think about poor perfusion, we see septic environment and techniques, we have tissue trauma, poor oxygenation, foreign bodies, poor debridement of necrotic tissues, and there are a number of other things as well, but these are kind of the 6 big ticket items. Okay, so that pretty much wraps up infection. Now moving on to dehiscence. So typically it's due to tissue failure. Okay, so it can be closed again in the OR or left to heal by second intention. And of course, if we leave it to heal by second intention and close it up with primary closure with sutures, that of course now is called third intention healing, right? We talked about that a little bit in the first video, if I remember correctly. So now a little bit about some of the outcomes, or I guess I would call these as well complications, right? So one of the biggest ones, of course, is proliferative scarring, okay, which is hyperproliferative healing. And there are 2 types of proliferative scarring or hyperproliferative healing. We have a hypertrophic scar and we have a keloid. So let's compare some of these. So some features of a hypertrophic scar are parallel collagen, and so actually let's compare one by one. So in a hypertrophic scar, you can almost think of that as the tamer of the 2. It has parallel collagen, while the keloid has disorganized collagen. If you've ever seen a keloid, I wish I had. This is a good picture of a keloid coming up in the next slide, but it doesn't even do it justice. Some of them are huge. So a hypertrophic scar, we have parallel collagen, and in keloid we have disorganized collagen. In hypertrophic scar, we have type 3 collagen, and in a keloid, we have type 1 and type 3 collagen. Hypertrophic scar doesn't really recur that much. Keloid, frequent recurrence. Hypertrophic scar is confined. Keloid, not confined. Then a hypertrophic scar typically occurs soon after the injury. Keloid can manifest months after the injury. Hypertrophic scar might go away. Keloid will almost never go away. And keloids definitely have a racial and familial predilection. Okay? So one thing that both of them have, or a couple of things that both of them have in common, is you have elevation of growth factors and neoangiogenesis, which causes stimulation of fibrous tissue growth. So growth factors like TGF-beta, PDGF, which is platelet-derived growth factor, IL-1, and IGF-1, they increase the number of local fibroblasts and collagen production. And then neoangiogenesis also brings vasoactive mediators and mast cells, which can cause the stimulation of fibrous tissue growth via histamine. So this whole thing is very self-propagating. And so we'll look at this picture here to look at keloids and hypertrophic scars, and this will be the last slide in this in this talk. And what you'll see is that in proliferative scarring, on the left-hand side we have a keloid, on the right side is the hypertrophic scar, and it's assumed to be related to a dysregulation of apoptosis. Okay, and it makes plenty of sense because if you think about it, inflammatory cells typically die off as the healing process progresses, and this seems to be an issue. These seem to be an issue with that regulated cell process, or that regulated cell death, okay? So there really is no treatment because, to be honest with you, our understanding of it is present but not thorough. So there's no real treatment, just attempted prevention. So we attempt to prevent it by trying to minimize protein synthesis. We might do steroidal injections into the scar to minimize fibroblast proliferation, angiogenesis, and collagen deposition. So that is pretty much it for this section of these tutorials. And in the next one, we still have a couple more wound healing ones, and I look forward to seeing you in those. And yeah, if you have any questions or any comments, please leave them below. And yeah, thank you. I'll see you in the next one.